Hello everyone. So today we're going to talk about the demyelinating disorders or the diseases of myelin. So what myelin is? Myelin is an electrical insulator that allows the rapid propagation of the neural impulses. It insulates the axons and improves the speed and the efficiency of the conduction. So oligodendrocytes myelinate the central nervous system and the Schwann cells myelinate the peripheral nervous system. And the demyelinating disorders are characterized by the destruction of the myelin or oligodendrocytes, and here the axons are generally preserved. So CNS diseases that involves myelin, they are separated into two broad groups: those that are characterized by damage to previously normal myelin, and that includes the multiple sclerosis and the viral infections that can cause damage to the myelin, and those diseases in which the myelin is not formed properly or has abnormal turnover kinetics, and that includes the leukodystrophy. So let's start with the first one, that is the multiple sclerosis. Multiple sclerosis is the most common CNS demyelinating disorder, and it is caused by the autoimmune destruction of the oligodendrocytes. Now, what is oligodendrocytes? These are the glial cells that forms myelin sheath in the CNS, and it affects women twice as men from the age 20s to 30, and it has the HLA-DR2 genotype. They have increased susceptibility to multiple sclerosis, and viral infection of oligodendrocytes can also cause the multiple sclerosis. So let's talk about the pathogenesis. It is unknown, but one theory is there that it may involve the autoreactive helper T cells that inappropriately respond to antigens in the myelin, and that in turn release the inflammatory cytokines. So talking about the morphology, grossly multiple sclerosis is characterized by the formation of the active plaques. Now, what are active plaques? These are the localized areas of inflammation in white matter of brain or spinal cord. On histology, the active plaques contain the abundant macrophages, contain abundant CD8 plus cytotoxic T cells, and B cells and plasma cells. They also play an important role in it. And the active plaques are surrounded by the proliferating astrocytes as a reaction to the nerve tissue injury, and that is then called the active gliosis. And the active plaques, they forms the normally they forms commonly near the ventricles, but they can also form in the optic chiasma and the brainstem, and a small proportion of the neuronal axon, it may be lost here. So talking about the clinical features, the multiple sclerosis characteristically presents with the neurologic signs and symptoms and relapsing remitting pattern of the symptomatic progression. The most important here to remember is the fatigue. So fatigue, particularly after the hot showers or the strenuous activity, and sensory and motor symptoms are also present. And important here too that we're going to discuss in detail is the optic neuritis. What optic neuritis is, it is basically the inflammation of the optic nerve, and it presents with unilateral eye pain and vision loss, and that vision loss is mostly, it affects the central vision. That's why we call it the central scotoma. And the unilateral eye pain, it gets aggravated by the ocular movements. And optic neuritis, it presents with the RAPD or the relative afferent pupillary defect. Now, what a relative afferent pupillary defect is, it is basically like when you shine light in the affected eye, so the bilateral pupil constricts less than the normal, means it stays slightly dilated. And this relative afferent pupillary defect, it is also known as the Marcus gun pupil, and it can be elicited on exam by shining light into the normal eye, then into the affected eye. So it goes like constrict, dilate, constrict, dilate, and that subtle defect from the affected side becomes more obvious. Internuclear ophthalmoplegia, these are basically the lesion in the medial longitudinal fasciculus that coordinates the horizontal eye movement. And so here is one example, like the lesion in right eye, it leads to the right eye, it causes right eye not to abduct in response to the abduction of the left eye, and that can cause the horizontal nystagmus in unaffected eye, and horizontal gaze problems can occur, but the convergence is fine. So multiple sclerosis can present with the Lermit sign. Lermit sign is actually a sign that occurs when there is neck flexion. With the neck flexion, the electric shock sensation running down the spine is basically the Lermit sign. And multiple sclerosis can also present with the muscle spasticity, intention tremors, and scanning speech. Scanning speech is basically a sort of like conversational intention tremors. Diagnosis of multiple sclerosis is made by the MRI and the lumbar puncture, and the MRI reveals the plaques, the area of white matter demyelination, and the lumbar puncture, it shows the increased lymphocytes, increased immunoglobulins with the oligoconal IgG bands on high resolution electrophoresis, and the myelin basic protein. Now, what are the oligoconal bands? These actually they represent the IgG antibodies, and they are produced due to the production of large amounts of immunoglobulin by the multiple B cells. So next we're going to talk about the those diseases in which the myelin is not formed properly or has an abnormal turnover kinetic, that is the leukodystrophies. So leukodystrophies are the inherited dysmyelinating diseases that are caused by the abnormal myelin synthesis or turnover, and here occurs the mutations in enzymes necessary for the production or the maintenance of the myelin. So it begins at a younger age, and there is diffuse involvement of white matter that leads to the deterioration of the motor skills, spasticity, hypotonia, and ataxia. And in morphology, grossly, you can see the white matter turns into completely more of a gray and the translucent, and on histology you can see the infiltration of the macrophages stuffed with lipids. So that's all you need to remember about the leukodystrophy.